I would like to request Dr. Sheetal now, and she'll also be talking about the MS39 and all-in-one refractive workstation.
Thank you so much, sir, and good evening,
Thank
everyone.
you.
I'll be talking briefly about MS39. Most of the technology part and its applications have already been covered by previous speakers. So I'll just briefly talk about the technology, and I have been using this since past 3 or 4 years, and it has been really helping me in my practice in improving my decision making and also evaluating the results of refractive surgery. So this is the most advanced device for analysis of anterior segment as of today, because it combines two technologies, the Placido disc corneal topography as well as a high resolution OCT based anterior segment tomography. Now it's a spectral domain OCT with a wavelength of 845 nanometers. Its resolution in air is 35 microns and in tissue 3.6 microns. Now basically if we look at the differences of MS39 from Pentacam, of course technology, the area mapped is much wider, 16 into 16 versus 9 mm. The points measured are also more, 36,000 odd points on the anterior cornea and 26,000 points on the posterior cornea, whereas Pentacam measures about 25,000 points on the anterior cornea. So curvature maps are directly derived from the tear film and anterior corneal surface. In the Pentacam, curvature maps are derived indirectly from elevation maps. What is available in MS39 and is not available in Pentacam is the epithelial thickness measurement, the stromal elevation and thickness map, optical quality analysis, OCT, corneal and angle section, tear film analysis and dynamic pupillometry. So keratoconus screening is very convenient to do. So what it gives you is basically notable point spread function. Now this is very easy to it's very easy to diagnose keratoconus through this. So basically you see the value of NPS. Normal value is more than 1. If it's borderline keratoconus, the value is within 0.6 to 1, and if it's keratoconus, it is less than 0.5. So it also gives you Gaussian curvature curves, which are thought to be more sensitive and depict true morphological picture of the pathology. So this essentially is derived by the mean of geometric mean of maximum and minimal curvatures at one point at the surface. Now if you see, this is a summary of a particular eye with keratoconus. If you just see the anterior and posterior surface, the regular maps, the size of the pathology is a particular size, and if you just see the Gaussian maps, which is just under these, so you can see that the keratoconus is more on the anterior surface than on the posterior surface. So it actually gives you a better morphological depiction of the pathology. Keratoconus progression has been already covered, even the epithelial thickness. Now I'll just show you few cases where this equipment actually helped me in better decision making in deciding which patient to operate or not for refractive surgery. Now this is a Pentacam map of a patient who has a low myopia, very low myopia. It's a thin pachymetry, 458 microns with a FFKC-like picture on bad display. Now in these cases you would be very worried and probably will not want to do refractive surgery or would go for ICL or something else. But when you see this map, the same patient's map on MS39, because it considers epithelial thickness profile as well and the Gaussian maps, etc., it has actually given me the report of normal. And since it is normal, I can probably go ahead with a PRK in this case. Another case with a thick cornea, FFKC-like picture on bad again. So again here, because the epithelial maps and everything is normal, I can probably go for a PRK or smile extra in this particular case. Advanced analysis of tear film, you don't need to do any of those invasive tests, Schirmer's 1, 2, and which is uncomfortable for the patient and also very subjective. So it gives you NIBOT, which is a non-invasive breakup time, and this is what we have been using for our refractive patients. And you see how it gives you the report is all the dry spots are highlighted as hot colors, and in this particular patient the NIBOT was quite low, around 5, and when we treated the dry eye you can see that it has improved to around 15, and the astigmatism, which was 1.5 and 1.8 earlier, is now reduced to 1 and 1.2. So optical quality analysis has also been covered, also the corneal abrasions. It segregates epithelial abrasions from the total corneal abrasion, so you know the source of the abrasions as well. Dynamic pupillometry is very important, especially while planning refractive surgery. Your pupil size, the optical zone, etc. It gives you pupil size in different light conditions, photopic, mesopic and photopic. And another thing that we have been using this for is to do the dynamic vault assessment post ICL or phakic IOL. So you can see that when the pupil goes from a scotopic to photopic condition, and as it constricts, the vault reduces. So that is the actual representation of the vault, which is the dynamic vault, which should ideally be studied. So you can see in this particular case, the scotopic vault was 266, but in photopic condition, it reduced to 227. So actually that is the vault which you should be considering. It also has advanced lens biometry, and you can use this for IOL power calculations as well. And I particularly find it very useful for post-LASIK cases, because this tool is basically based on the ray tracing principle, and it gives fairly accurate and comparable results with the Barrett, TrueK, TK, all those advanced formulae. It can also be used for intrastromal ring segment planning. This is a case showing ICR in situ. So in conclusion, MS39 has multiple useful functions for a refractive surgeon to enable an anterior segment surgeon better understand their patient's visual needs and requirements and choose the most appropriate course of action to address them. Thank you so much for your attention.